And so when I think of kind of looking back at some of that history and what the issue is, what are our goals of regional therapy? It's actually two-pronged, and the surgery consists of kind of two different parts. The first part of this is this cytoreductive surgery, or often abbreviated CRS, and that's removal of all visible tumors that we can kind of see with our eyes in the operating room. The second part is the Hipec surgery. So that's the Hipec part, and that's the warm chemotherapy perfusion. We use a pump that keeps it warm and kind of lets the chemotherapy solution bathe through the abdominal cavity, so that to try to access all of the compartments and kind of in between organs and things like that. And so that's really used for the goal of that is basically for cells that we can't see with our eyes. Sometimes there's fluid in the abdomen and there's cells that are floating around and we just can't, they're too small to see with our eyes. So the idea for the Hipec, the chemotherapy bath, is to try to disrupt or kill those tumor cells before they can implant and cause recurrent tumors. These are some of the chemotherapy drugs that are most commonly used especially for colon cancer and then gastric cancer. The idea behind the heat, you may ask why heat? The idea is that it kind of increases some of the penetration of some of these drugs. There's been a lot of thought on these drugs and their size and how much they penetrate and go in. And so balancing that versus getting into the systemic bloodstream. So I mentioned earlier this blood or this plasma peritoneal barrier, which was kind of hindering things from going from the bloodstream into the peritoneum. But in this case, we use that to our advantage a little bit. And we try to give slightly higher doses of this chemotherapy because now we know that it's not perfect. Some of it may get into the systemic system and cause potentially some side effects, but not as we can use higher doses. It's not as high a rate. And so we're kind of maybe using that barrier to our advantage to sort of keep it in the peritoneum rather than giving it in the bloodstream where it would go everywhere and be a little bit more toxic. And so then I just wanted to reiterate that the two go hand in hand. Removal of all visible tumor is pretty critical for Hipec because if you're leaving a big tumor behind, the Hipec is probably not going to penetrate, an inch or two deep and be able to kill all that tumor. So it's really, they both go hand in hand, and I think are important aspects of the surgery.